Okay, so I'm going to talk about how to titrate basal insulin, and when should we think about adding something on top of the basal insulin. So I have about 30 slides, but if you want to stop at 15, I'm fine with that. So so we will start with the first slide here. I will start with a case that I saw, I think, last Friday, and I think that's a good case. So she was sent to me because of, she's a 66-year-old female who has had diabetes for the last about 18 years. The primary care physician has been trying hard to control the blood sugars, but in the last 2 years, her A1Cs were ranged between 8.5 to 9.5. She used to be, for the major part of her disease, on full dose of metformin and on glimepiride, 4 milligrams daily. But because the A1Cs were running high, closer to 9.5 in the last 2 years, insulin was initiated about 6 months ago. In the 6 months since the initiation of basal insulin, the A1Cs improved some. They were 8.7 after 3 months of basal insulin use, and then 8.4. So she came to see us on Friday, and her medications at that time were Lentis, which is basal insulin 12 units, and glimepiride was stopped after initiation of insulin, and on metformin full dose, 1 gram twice a day. So these are the blood sugars that the patients brought in. Actually, she had it written down somewhere else, so the nurse actually transferred this on our piece of paper. So if you see here, the BB, and on the first slide there after the date is the before breakfast numbers. So these are the fasting numbers. On 12 units of insulin, her average is more than 160, almost closer to 180 as the fasting sugar. So 167, I see 191 there. There's a 218, 180. And predominantly the average is more than that. So that is the first thing we need to look at. And throughout the day, she's checking it at other times of the day, and the numbers are fairly constant. Constant in the 160s to 170 range, with occasional 200s depending on what she's eating. So right now she's on basal insulin 12 units that she's been taking at least for the last 3 months. She was started on a lower dose and then titrated up. And she is on full dose of metformin. So the question is, what should we do next? So these are some of the options that we have. None of these options are wrong, or it's possible that a combination is correct as well, but these are the options that we have. We can titrate her Lentis insulin to achieve a fasting blood sugar of less than 130. Right now, she's around 180 on average. We can add a rapid-acting insulin before meal. We can add, 3 injections actually we can do before each meal. We can add rapid-acting insulin just before the dinner, which is her biggest meal of the day. We can talk to her about adding a GLP-1. A daily or a weekly injection. We can add an SGLT2 inhibitor, or we can do a DPP4 inhibitor. I should tell you, which I didn't mention initially, that her kidney functions were normal. Her GFR was greater than 60, and she was appropriately on the full dose of metformin as a result of that. So these are some of the options that we have, but what I want to discuss is what should we do in a step-by-step fashion. So she is on full dose of, she's on a moderate, I should say, dose of insulin, and her fasting blood sugars are greater than 160, in the 180 range. So the first thing is that she is to do is to titrate her basal insulin in this situation, to target her fasting numbers. And you can always set a target depending on how frail the patient is, how insulin naive the patient is. But in most patients, what we do is normally set a target of around 140 as a fasting blood sugar. And we can ask the patient to titrate the insulin slowly. By if the blood sugars are still more than 140 consistently after a week, then we can increase the insulin. The problem that we see and we have noticed is most of the times patients are started on a fixed dose of basal insulin, and then the titration never happens. So this patient was on the same dose for the last 3 months. If you are prescribing this, the Lentis insulin, you can certainly ask the patient to check the fasting blood sugars, and if they are higher than your target, consistently higher than your target, then after a week or 2 weeks, they should increase it by 2 units to achieve the target. So I think that's the first thing we should do, and whenever we start basal insulin on a patient needs to be educated about it. So, and we should also tell them we titrate and to achieve our targets, and monitor for symptoms of any nocturnal hypoglycemia, any low blood sugars, early morning low blood sugars. And we should educate the patient that if they start developing nightmares or waking up hungry or having sweats at night when they're waking up and their sheets and clothes are all wet, these are some of the signs that can indicate that the blood sugars are dropping in the middle of the night. And in that situation, increasing the basal insulin will be the wrong thing to do. If they're having these problems, then they should check their blood sugars at about 3 to 4 a.m. in the morning. Make sure that they are not dropping. And if they are dropping, then we should actually lower the basal insulin and not increase it further. So we should educate them to titrate, and at the same time, tell them if they are having symptoms, they should check the blood sugars at 3 to 4 a.m. In the morning. So I think that's the first step we will do on this patient, titrate. But if in spite of, and this is the problem that can happen in these patients. So basal insulin is a true 24-hour insulin. Our body makes some insulin. I mean, she has had diabetes for 18 years, so most likely she's not making any insulin. But the major time of increased insulin requirements is during the day, immediately after breakfast, immediately after lunch, and after dinner. But if we keep titrating the insulin, and especially if you're giving it at bedtime, this time after the bedtime, this is a time of low insulin requirement because the patient most likely is not eating anything. And if we keep titrating the dose, then this is where low blood sugars can still happen even with the basal insulin, because this is a period of the day or the night where the insulin requirements are low. So that is what we want to prevent. We don't want the patient to drop in the middle of the night. It can cause all sorts of complications from hypoglycemia, including ventricular fibrillation, and patients can actually die if that happens. So titrate the basal insulin, but educate the patient. So I think that's the first thing. And the titration should be done every 1 to 2 week basis. And this is, just to explain to the patients or to remind ourselves that insulin, when we are prescribing someone insulin, it's just that we are replacing something that they don't have anymore or they are not making anymore. So most diabetics, when they're diagnosed with diabetes, they have lost most of their beta cell function anyways. And with time, their insulin production, so this is when they had the kind of pre-diabetes here, many years before they developed the true diabetes, and their beta cells shown here in blue continue to drop, and their insulin levels continue to go down over a period of time. So, and as a result, when their pancreas are not making enough insulin, their blood sugars start going up and up. So if the patient has diabetes for a long period of time, 10 plus years, then mostly they have lost more of the insulin production anyway. So they need insulin. And we are just giving them something that their body is not making. And giving them medications such as sulfonylureas to stimulate the pancreas is probably not the right idea at this stage if they have the disease for about 10 plus years. So basal insulin is a good way to start in such cases. So, I don't think we need to remember the numbers here, but in this country, the average A1C where insulin is initiated is around 9. 9 plus is because we, as providers, want to try everything else before we go to the insulin, and insulin is normally looked at as the last resort. So we normally start insulin, as prescribers, we start insulin rather late in the disease, although we know that like this patient, she had diabetes for about 18 years, but the insulin was started just about 6 months ago. And most likely the glimepiride was not doing anything for her anyways, because the pancreatic functions were not there anymore. So, and when we start the basal insulin, I think we start too low of a dose. Like she was started on only 6 units initially, and then was doubled to 12 units. And what we have seen is after 3 months of initiation of basal insulin, most patients are still not at target range. Their A1Cs still stay higher, and in fact, in 20% of the patients in the studies, the A1Cs still stay more than 9%. So I think what we are doing is we are starting low, and we are reluctant to titrate the basal insulin fast enough to bring the A1Cs down. Similarly, and this is another study which showed pretty much the same thing, that the only 40%, so about 1/3, were able to achieve a target A1C of 7%. And those who did achieve it, their A1Cs were low to begin with. So I think we should start the insulin. I'm fine with starting the basal insulin low, but we should titrate on a 2-weekly to 3-weekly basis, and the patient should be educated so they can do it themselves before they come and see us. They should be able to titrate their basal insulin. So I think that's the takeaway from this. Now, when should we think about adding something to basal insulin? What is the point where we should think that we have intensified our basal insulin and should move on from basal insulin to something else? So if a patient has A1C greater than 7 and their fasting blood sugars are consistently less than 130, that means that we have intensified our basal insulin to the maximum level. And at that point, we should think about adding something to basal insulin. Because if we keep titrating the basal insulin when the fasting blood sugars are less than 130, like we discussed before, we will cause low blood sugars. We will cause nocturnal hypoglycemia, which will be dangerous for the patient. So that's one thing. If your patient is coming in when the fasting blood sugars are consistently less than 130, that's one indication. And the second is if their basal dose is too much. And what is too much? Anything more than 0.5 units per kg per day. So if they weigh, say, 100 kg and they are on 60 units of basal insulin and only basal insulin, that means they are getting too much. So we look at the weight, we look at the dose of the basal insulin, and we also look at what their fasting blood sugars are doing in the morning. And based on that, we should have a discussion with the patient about maybe adding something at that point. So what are our options after the patient we have intensified basal insulin, we have controlled fasting blood sugars? Metformin is one. Now, most patients should be on metformin when they are already on insulin, but we always see patients where they were prescribed some form of metformin and they developed some GI side effects. So most patients take metformin, but they are not on metformin by the time they come and see us for one reason or the other. Some reasons are an absolute indication not to use metformin, especially if they have kidney functions, GFR less than 30, or if their GFR is between 30 to 45, then we should reduce the dose. But we should always revisit why they stopped taking the metformin. Was it just because of some GI side effects? We can use an extended release metformin. We can use a low dose metformin at bedtime to help minimize the dose-related GI disturbances. But we should always make sure if there is an indication to use metformin, we should add metformin. Then the other options are we can use pre-meal insulin, either once with the largest meal of the day or with all 3 meals of the day. Mostly if they are decompensated, meaning if their A1Cs are extremely high and they're symptomatic, they're having polyuria, they're having low energy, or they're losing weight because of extremely high blood sugars, then yes, we should start 3 times a day because their pancreas are totally non-functional. But if in a patient like mine that I presented, if we have intensified the basal insulin, the next step will be to maybe just cover with 1 pre-meal insulin before the largest meal of the day. That will be the next step, because the patient is certainly not decompensated as far as the blood sugars are concerned. The other option is if the patient needs more than 2 injections, needs a basal insulin plus at least need 2 pre-meal insulins, and the patient is reluctant or cannot take 3 injections, then we can try, although it's not the preferred method, to use a premix, an NPH and regular insulin, or an overlog mixed insulin, which is a combination of both an intermediate acting insulin and a short acting insulin, which will provide the pre-meal coverage and also will provide intermediate acting insulin. So that's an option. DPP-4 is an option, predominantly for patients with poor kidney functions or frail patients or elderly patients, because it's a safe medication, although it's not a potent medication. GLP-1 receptor agonist, that is an option, especially if the patients are obese and appetite is an issue, and especially if they have cardiovascular disease, and we will talk about this in detail when we go to that, or SGLT2 inhibitors. Again, cardiovascular disease, CHF, and if they have normal kidney function. So those are the few options after intensifying the basal insulin. So that's pretty much what we have just said. So if we have achieved our the morning targets with the basal insulin, fasting sugars are less than 130 consistently, then we can add 1 rapid acting insulin before the largest meal of the day. So that's option number 1. If after doing that our A1C is still not controlled, then we can change it to basal bolus, meaning continue with the basal and cover most meals of all 3 meals of the day. So that's one option. The other option is to add a GLP-1 receptor agonist. And if the A1C is not reached to our target after using a GLP-1, then we can add a bolus insulin as well. The other option, like we discussed before, if the patient is needing more than 3 injections and the patient is reluctant to take the more injections, then we can use a premixed insulin, a combination of an intermediate acting and a short acting insulin, and provide that basal bolus coverage with at least with 2 meals of the day. Any questions about this so far? Okay, so this just highlights one thing, that if a patient is not decompensated, but the A1C is high, there is really not a whole lot of advantage in giving them 3 bolus insulins or 3 pre-meal insulins right off the bat. So this just shows here these patients were started on basal insulin. This is the run-in time for the study. Their A1Cs were more than 10. So the first 3 months, they were just on basal insulin, and the basal insulin was titrated. And here, they were started on a short-acting insulin, the Epidra. The orange represents when they were just taking 1 injection a day. The green here shows when they were taking 2 injections of short-acting insulin, and the blue represents 3 injections. At the end of 3 months after this, there was a little bit of a difference in the A1C control, but it was really not a huge amount. So the patients who were taking 3 injections a day, their A1C was 7.44 versus those who were taking 3 injections or 3 glulisine, which is a Epidra injection before meals, their A1C was slightly lower at 7.29. But clinically, is it a major advantage? Not really. So I think once we start them on insulin and titrate the basal insulin, and their numbers are still high, then I think using 1 injection to reduce the injection burden for the patient, we should just cover the largest meal of the day, or just have them take the insulin, the bolus insulin before the largest meal of the day. And it will bring their numbers down, because if their A1C at this point was was coming down from where they were here actually. So this is where they started on the basal insulin. Their A1Cs came down just by titrating the more fasting blood sugar from 10 point something to 7 point maybe 9 or closer to 8. And after adding the bolus insulin, it did come down further, but there was really not a major advantage in giving them 3 injections versus 1 injection. So yeah, we already talked about this. If they need more than 2 injections and they cannot take it, then we can do a premixed injections as well. Okay, so how should we start the bolus insulin? So we have maximized the basal insulin. What is how should we go about adding a pre-meal bolus insulin? So, and this is just the ADA recommendation as to how should we start. So they're recommending that we can use about 4 units of bolus, Novolog, Humalog, or Epidra. So we can just pick a number of 4 units, or we can do 0.1 units per kg. That's a weight-based dose, or 10% of the basal dose. We can use any of these 3 options. If we are worried about that the patient will be hypoglycemic, or patient is sensitive to insulin, then I think we should pick the lowest number. So suppose if they are 100 kg, that will come out to be about 10 units. So this will be much more than the 4 units. And if they are taking 100 units of basal, which is too much, then this will be 10-unit dose. So always go with the lower number first for the short-acting insulin, because it will cause the glucose to drop. So we can pick any of these numbers. If their A1C is low, then we should at the same time reduce their basal insulin as well. So if suppose this patient, my patient that I just described, was on 20 units at that time, and I decide to add some bolus insulin, then I will start the 4 units, but I will reduce the basal insulin from 20 units to 16 units. So I will take that away from the bolus dose just to prevent the hypoglycemia. And then again, after we start it, we should titrate. We should keep titrating, and we should educate the patient to titrate. So they can go up by 1 to 2 units or 10 to 15% of their bolus dose about once or twice a week if we are not able to achieve our blood glucose targets. And the targets will be, for example, if we set a target of 180 or less after a meal that day we are giving them the bolus insulin for, then we can always increase the bolus dose from 4 units to maybe 5 units, and then check the blood sugars 2 hours after and then monitor it. So if they're taking 4 units of Novolog and their pre-dinner number is 140, but after dinner, 2 hours after dinner, their number is 200, then that means I need to increase the dose of the Novolog, and I will probably just add maybe 1 to 2 units depending on how high they are. And they can do that themselves as long as we tell them what to do. So by the time they come in the next time, 3 months later, then they've already achieved that. And if they are having hypoglycemia after our pre-meal or the bolus dose, then we should address that. We should ask them why this is happening. And if this is happening, we can always reduce the dose. If they are on 6 to 8 units, then we should reduce it by 2 to 4 units or a 10 to 20% reduction to prevent hypoglycemia. Okay, so I think we will talk about the premix today as well. So these are the options that we have for the premixed insulins. Now, again, this is the NPH and the regular insulin in the ratio of 70% to 30%. So 70% of the dose will be NPH, the intermediate acting insulin, and 30% of the dose is the regular insulin. So if the patient is taking 20 units of this insulin, NPH and R, then that means 14 units is NPH and 6 units is the regular insulin. There are other options as well. The Humalog mix comes in a 75-25, whereas in this combination, 75% of the dose is neutral protamine. This is the intermediate acting insulin, and the 25% is the Lispro dose. There is a 50-50 mix of the large amount. Oh, okay.
They're just connecting.
All right, okay. So it's a 50-50. So if the patient eats a large amount of carbohydrate, then we can use a 50-50 combination where 50% is the intermediate acting insulin and 50% is the bolus insulin. That is in patients who eat a lot of carbohydrates. So we give them more that way. Then there's a Novolog mix, which is a combination of intermediate acting and a true short acting insulin. So there's a difference between this 70-30 insulin and the NPH and regular 70-30 insulin, because this contains regular insulin with NPH, and this contains our Novolog, which is a different pharmacokinetic than the regular insulin. And then this is a new insulin which is about to come out. This is our Tresiba, with the Novolog insulin. So it's a different insulin. It's not available. And the whole idea is the same thing. 1 bolus insulin before the largest meal of the day. Tresiba is is a long-acting 24-hour insulin. So this insulin will be given before their largest meal of the day to reduce the injection burden further. But this is not available at this point. And if we are using a pre-mixed insulin, so this is how we should titrate it. So what we should do is, if we know the basal requirement of the patient, basal insulin requirement of the patient, then we can divide the dose into 2/3 of the dose. If suppose they're taking 100 units, I'm just giving an example, then the 66 units will be in the morning, and 1/3 of the dose, which will be 34, if they're using 100 units, will be in the before the evening meal of the day. Again, we don't want to give a larger dose in the evening time because of nocturnal hypoglycemia, but we can, if the patient is running high consistently both in the morning and at night, we can actually divide it into half and half. But most of us, I think, use the 2/3 and the 1/3 combination because we do not want them to drop in the middle of the night. Nocturnal hypoglycemia is dangerous. And then, like we have talked before, we discussed before, we should increase depending on how the blood sugars are. We can go slow, just 1 to 2 units, or we can make a 10 to 15% increment on a weekly to bi-weekly basis, depending on their blood sugars. Again, like we discussed before, if they are having low blood sugars, then we should decrease the doses. Whatever dose we have started them on, we should reduce it by 2 to 4 units and address why the hypoglycemia is happening. Are they developing kidney problems? Are they not eating as much? They have started any diet, or they are more active, and address the main issue. So again, this is just to show there is benefit to using the premixed insulin, but there is a problem as well. And this is this is a study which just shows that using premixed insulin, a combination insulin, the A1C did go down, but not as much as with basal +1, where they were on basal insulin plus just one prendial insulin, or also when they were on basal insulin plus 3 injections. So the A1C reduction is less with premixed insulin, and there is more incidence of hypoglycemia because of the different pharmacokinetics. So this is an option, but it is not as good as an option as you compared to using a true basal insulin plus a true bolus insulin, because the pharmacokinetics are different. So if we have no other option and the patient either cannot afford it or cannot take 3 injections and is okay with taking 2 injections, then we should use it. But if the patient can truly take 3 injections or more injections, then we should try and use basal insulin plus a true bolus insulin because of the better A1C reductions and less hypoglycemia than with the other insulins. So this is just a comparison. I think we have already discussed this. If your patient is on basal insulin initially, then we add 1 injection of a true basal bolus insulin before the meal. There will be less weight gain and less hypoglycemia as long as we are using the doses that we have discussed. With the 3 injections, so that means this patient is taking 4 injections a day. It's more complex. There is more risk of weight gain in these patients because they are on large doses of insulin. They're taking more insulin. With that, there is increased chance of hypoglycemia as well. And similarly, in premixed insulin, if they're using 1 or 2 injections, more weight gain and more hypoglycemia. I think I will stop here, and if you have any questions about what we have discussed, we can, and we will continue with this using GLP and SGLT2 or DPP4 in the next part. But so today what we discussed was titrating the basal insulin for the fasting blood sugars. When should we decide about adding a bolus insulin before the meal? We can always just start with 1 injection before their largest meal of the day. If it's lunch, it should be before lunch. If it's dinner, then it should be before dinner, and then titrating upwards with time, setting the targets. What are our targets 2 hours after the meal, and then titrating the dose accordingly.
So I have a question. This was really excellent. There were some new points that I learned, so I really appreciate the presentation. if you add a pre-meal bolus, you said that when you initially do that, you want, for example, if you started with 4 units, you want to reduce your basal dose by 4 units. Each time you titrate up the pre-meal, do you then reduce the basal by that same amount, or can you leave the basal where it is?
It depends on how sensitive you feel they are with insulin. And the other thing is, I will only do it if their A1C is tight. You know, if it's 8%, then I will do this. If their A1C is 9.8%, then I will not do it. I will just continue with the basal and give the bolus. But you're right, if you are titrating the dose up and you feel that they're very sensitive and their A1Cs are tight, then I will in this situation. So it's a case-by-case basis. 8% is where, you know, we feel that they have less cushion and they can drop. Their blood sugars are running tight. So yeah, then I will make the change.
Very helpful. Thank you.
Yeah.
Are there any other questions, comments?
Jen, I just wanted to add, thank you for your presentation on the empty cella. And I just wanted to add one thing about trying to differentiate someone's hypothyroidism from being central, like out of the pituitary,
right,
from primary in the neck. Another tip or trick is doing a TPO antibody.
Okay.
So like Adnan said, you could add the free T4, but you could also add a TPO antibody, because that thyroid peroxidase antibody gives you more of an idea that the thyroid disease is actually at the level of the thyroid gland, right, as opposed to central within the pituitary.
Right.
Now you can have patients that have both. I have seen that as well. But that's just one thing that can also help you differentiate.
Okay, that's a good tip. Thank you.
I have a question about the insulin. I joined in the middle of the presentation, so I don't know whether you have already answered this. The newer insulin, like the Tresiba, Basal, okay, I mean, they are being promoted that the risk of hypoglycemia is less and their duration of action is up to 48 to 42 hours. Okay, so how true is that in the practical life?
Sure. So Basal, you mentioned Basal. I just want to clarify. Basal is the glargine insulin. It's the same thing as the lentis insulin. So it's the same molecule. Your Toujeo is also glargine insulin. So the lentis, it's just the U300 insulin, the Toujeo. The Basal is the U100 insulin. So they are, you know, absolutely similar. So there is very little, if any, difference between the lentis insulin versus the Basal insulin versus the Toujeo insulin. With Toujeo, you have less volume because it's U300. So if a patient is on a very large dose of insulin, that's where you will have advantage using Toujeo, because the pharmacokinetics of the dose will be different in higher doses. So that's one thing. The second thing is, you mentioned about the insulin Diglodag, which is the Tresiba insulin you mentioned. That is a different molecule altogether. It's not the glargine insulin, and it has a different pharmacokinetics altogether. And it is slightly longer than the Tresiba insulin. So, but it's still a once-a-day insulin. It is not that you can skip a day and take it every other day and you will still be fine. The only advantage is, because it is slightly longer than 24 hours, I don't think it's up to, I know you're absolutely right that they're saying that it's up to 36 hours to 38 hours to 40 hours, depending on what study you look at. But I think it's slightly longer than our current basal insulin. So the advantage is the patients can take it, if suppose they work different schedules, and one day they take the insulin at 8 in the morning, the next day they cannot take it up until noontime. I think that's where Tresiba or insulin Diglodag has an advantage. So that's one benefit of using this insulin. The other one, as you mentioned, the hypoglycemia incidence is slightly low in studies, not by much, but because it has a different pharmacokinetics, it really does not have a true peak. So if the patients are taking it, their incidence of hypoglycemia is a little less compared to but not by much. But and that is because it's a different molecule altogether. It is not insulin glargine.
Thank you.
Also add to that too, understanding how patients, if they have underlying kidney disease, which a lot of diabetics do, if their GFR is reduced, you always want to consider that some of these basal insulins are acting much longer than what, the pharmacology insert says. So if their GFR is falling, the insulin is hanging around much longer. It can also predispose them to hypoglycemia.
Is there, to follow up on what you just said, is there some cutoff point where when a GFR reaches X, you start reducing insulin, or you just have to watch the patient?
The blood sugars. That is your cutoff point. When you start, sorry, Evan.
No, go ahead. Yeah.
Yeah, so I titrate to blood sugars, and I see someone's blood GFR falling. I try to tell them in advance, we may need to decrease your insulin doses because insulin is filtered through the kidney. So as the GFR falls, the insulin dose may be decreased as well. And so anything, blood sugars that are hovering around 70 or 80, I start reducing across the board.
Okay.
I have another question. So one thing I think that will change my practice from today is usually I have well, I'll put it this way, I have better guidelines now about when to go from basal, whatever dose of basal, to adding a bolus, because usually I just push the basal, push it. My question is, several years ago, I started seeing the endocrinologist who I was consulting with splitting the long-acting into BID dosing, and I checked with a couple of the people I work with, and they advised that in these very high doses of basal that's advisable. Do you agree with that, to split the basal long-acting into BID?
So that's a very good question, actually. To answer your question, I think I agree with the first part. If the patient is on a big dose of U100 insulin, and that's important because of the volume, if they are using 120 units in a day, then yes, I think splitting the dose is the right thing to do because of the volume. The pharmacokinetics, the absorption will be different. They'll be able to absorb the insulin better if you split the dose in that situation. But with some of these new U200, which is insulin degludec Tresiba, or the Toujeo, which is U300 insulin, because again, if they're using 60 units of U100 and then they're using 60 units of U300, the volume is 1/3. So you can actually, if the patient can take 2 injections, fine. But if they're missing injections just because they forget to take the other big basal insulin dose, then I will use the Toujeo and I'll try and give them all at once because the volume is 1/3 of what they were getting before. So yes, if you have one U100 insulin, then splitting, I normally split if they are reaching more than 50 units. So if they are, say on a 100-unit dose, then I will want to give them 50 and 50. But if they are missing injections because they are already taking 3 bolus injections and now because they are on Victoza as well, then I'll probably just give them 120 units of a Tresiba or a Toujeo insulin because of the volume.
Thank you.
Jen, I think that's a common thing when you preface that question by saying that you push the basal as much as you can. And I think that we have all done that at some point. And I think that's a really common first thing that Dr. Heather was really trying to speak to, is that basal insulin is just to satisfy a person's basal needs at night when they're sleeping and when they're fasting in between meals, and to metabolize that blood glucose at fasting times. It's not meant to take care of that food bolus, that we have with carbs. And honestly, in today's society, that is our biggest issue. Do you need us? Okay.
Who is there? Oh,
Yeah.
11:40. Oh, okay. Yeah, yeah, but
Already.
Yeah, that picture told 1,000 words, that graph. I mean, you know, we've all seen the graphs of insulin and sugar and stuff, but to see that today and backing up that really made it sort of shifted my brain.
Insulin's a flat line. It doesn't have peaks and troughs. When we eat a sub for lunch,
Right.
basal insulin does not peak up
Right.
and cover that glucose excursion. That's what your mealtime is. That's why I tell people you have fork in one hand, insulin pen in the other. Because basal does nothing for your post-meal glucose.
Yeah.
I'm sorry, Dr. Heather has to go. He has a patient that's here.
Thank you very much. That was a great presentation and day. Thank you, guys.
thank you.
Alrighty, so we'll call it. Everybody, that was a wonderful session. I really appreciate everybody participating. Jennifer, thank you for the case. And Dr. Heder, thank you so much for the didactic. We have had some really good feedback about our endocrine echo sessions. I'm very, very happy with it. Yeah. And, you know, we've had a couple of people talk about how it's even changed their own habits. So it's just been wonderful. So everybody, I'll let you know when the next one's coming up, and everybody have a wonderful day.
Thank
you. Yes, I will send out the presentation as well. No worries about it.
Thanks, Evan. That was wonderful. Thanks, guys. Take care.